Okay, nice. So we're recording now. Hi, everybody. Welcome back to another week of Road to the PSA. Thank you so much for joining us this evening. Today, we'll be going through psychiatry and the key sort of psychiatric medicines and things to know for the prescribing safety assessment. We've got Moji with us today, and also really exciting, we've got Dr. Bose with us as well, who's helped design and deliver this series. So Catherine, Dr. Bose is in the chat to answer any questions you guys have. And when we do questions together, Catherine will pop in saying, okay, this is the question. And if you guys like the message to say when you've finished, then that'll also help Marty know when to move on. Because I'm sharing slides, I won't be able to see how many people have liked that. So Catherine, if you don't mind unmuting yourself just to let us know when the time comes. And then, yeah, I think we're good to go. So Marty, whenever you're ready, do go ahead.
Thanks very much, Charlotte. I'm Moji. I'm an F1 currently working in community adult mental health in Winchester, which is why I've taken on the psychiatry kind of set. I'm going to just give a disclaimer in saying it's been a while since I've done my PSA. So a lot of this kind of information is going to be quite clinically based and kind of from my experience on community psychiatry. And then I've done my best to link that to the PSA. So next slide, please. Have I lost you guys? Hello, I'm back. Okay.
No, we're still here.
Fab. So just to go through what the session is going to look like, I'm going to start off with some treatment summaries that kind of apply specifically to psychiatry. I'm going to go through my personal top tips for the PSA and using BNF and Medicines Complete and all of that stuff. And then we'll go through some practice questions of each type of question, and I'll do some little slides of information in between as well. Can I have the next slide, please? So treatment summaries, there are a few. So for kind of depression or antidepressant drugs, you've got depression treatment summary. That's going to give you what's going to be first line, second line, etc. And then antidepressant drugs is its own title as well. And that goes into a bit more detail about the different drug classes and things. So they're both kind of useful to be aware of. Psychoses and related disorders is helpful for antipsychotics, intramuscular antipsychotic use, so depot, and clozapine as well. It's got quite a useful section in it about all the side effects, because in terms of psychotropic medications, a lot of the focus when you're selecting which medication to prescribe the patient is going to be related to that side effect profile, because actually the efficacy for the most part is very similar. And then we've got mania and hypomania, that's via lithium, sodium valproate, etc. Hypnotics and anxiolytics, if you're looking for benzos, Z drugs, so sleeping tablets and things like that. And then I've just included substance and opioid dependence on there as well, although we won't be doing much on substance misuse today. Next slide, please. So in terms of the PSA itself, like I said, with psychiatry, efficacy is very similar across most medications in a drug class, with very few exceptions like clozapine. So really, it's just getting comfortable with your adverse effects. And I'd say that the PSA likes to ask psychiatry questions in the context of adverse effects as well. Some practical tips. So I remember waiting for my PSA to start. I literally had like an hour of sitting around beforehand while we were sorting IT and logins and stuff out. So you've got plenty of time. Make sure you know your logins. And then I opened up a few tabs so that I'd save time in the actual thing. The interactions checker on Medicines Complete, which I can attempt a live demonstration of. We've got BNF treatment summaries, which I had open as another tab. Appendix 1, which is going to have all of your common side effects and electrolyte disturbances, things like that. And then I just had a spare BNF page. Everyone kind of learns their own style of doing things. Control F, I think it will have been mentioned in previous sessions that you can use Control F to look up side effects and to speed things up a bit. Just be cautious using it because the BNF isn't always consistent in its terminology. So something like raised prolactin might be under raised prolactin, hyperprolactinemia, galactorrhea, gynecomastia, whatever. And so you it creates pitfalls, if that makes sense. So just be cautious of that as well. And then, yeah, just get comfortable with split screen because, again, it's going to save you lots of time. Is it worth me trying to share my screen again, Charlotte, just to do the medicines complete?
Yeah, should we maybe give that a go? Just because I think people would really benefit from seeing how to use the interactions checker. So let's just give it a try.
Yeah, let's try.
Thanks for bearing with us, guys. It's just so that you
Sorry,
can actually
guys.
see the slides while we go.
I swear it was working perfectly.
It was. We've literally been on this call since 6 p.m. practicing, making sure everything's fine.
No big deal. How are we doing?
You're always fine at the start and then you go blurry, but I'll let you know.
Just let me know. Yeah. Okay. Fine. So you guys will all have Medicines Complete logins. I think you may need to make an account, so make sure you do that. You're only allowed to use the BNF section of Medicines Complete, so you can go ahead and just click BNF. And then it's a bit of like a weird roundabout way of getting to it. But so you look up any medication and then it's going to come up with this page, and you're not going to click interactions here. You're just going to search that medication again. And then you're going to click on interactions here. And then you're going to get your interactions checker. And then obviously here you can just type in any medications you have and search, and it will search them for interactions. To be honest,
so just to be clear, you do two searches. You do search once and then you put it back in the search bar.
Exactly. It's a bit, what I used to do for practicing was any PSA question that I was reading, whilst I was digesting that question, I would just quickly stick all the medications into the interactions checker, ready to go. It makes sure that you don't miss any interactions when you're prescribing something. It helps with prescription reviews, etc. So if you feel like you can afford the time to do that, I would get in the habit of doing that and just getting comfortable with it.
Do you mind doing it again, Moji? We've had a couple people, some thought it was maybe the same as the BNF checker. Some have asked if you could do it again. It's one that people don't actually know about. Like Medicines Complete is quite new. So if you could just show how people
so the BNF, you can use the BNF for interactions as well. But the thing about it is, I think the app version has a proper interactions checker and the web version doesn't. Here we go. So this is how I get onto it. There might be a better way. You have to click on BNF. You can't click directly on interactions checker because it's not technically BNF. And then we're going to search any medication on here. And then once we're on this page, if I go to interactions here, it's just going to take me to the list of interactions for atorvastatin, which I don't want. So I'm going to search at the top again. And then I'm going to go to interactions on the side here, and it's listed under BNF. And that's how you get onto the interactions checker.
Perfect. I think you went a bit blurry again, but I think the last one wasn't blurry when this one was, so we can put it together. We can also make like maybe a screenshot of how to do it all as a sort of flow through for people.
I have put a bit of a flow chart here.
You're wonderful.
Yeah, but we can include screenshots as well. Any luck on the blurriness?
One of my friends has just said if you right click on the desktop, then click display settings and change the scale to 100%, it might help.
So
one of my little genius buddies in the back.
Oh no. Guys, my computer is old. I'm sorry.
I can hear the fan working overtime.
Yeah. Okay. So right click on the desktop.
Yeah, and then it said desktop display. I don't know. I think it might be part of the slideshow thing on me. I don't know.
Oh. Is it better if you again
Shall we just
verified.
stick with what we know? Yeah, I'll do it.
Sorry about this, guys.
It's okay. You showed how to use the interactions checker. That's something we've not been
That's
shown
the main
before.
one. If anyone struggles with using the BNF, we can always swap back again. But for the most part, I think the rest of it is going to be fairly straightforward.
Tasty stuff. Here we go.
Okay. We shared.
Can you see?
Sorry, I'm just sorting myself out.
Who needed all that prep time? If we'd known, it would have just gone like this as soon as they started.
So annoying. I've lost my teams.
Oh. Well, we're still here.
Okay, here we go. Cool. Let's get on to the first question.
Okay. Prescribing practice.
So 28-year-old male attends GP, 3 days of markedly elevated mood, pressured speech, and reduced need for sleep. He's irritable, and he's just spent some money even though he's in debt. We've got a past psychiatric history of bipolar type 1, not currently on any medications, no allergies, bit of information about the social history, and we're looking for a medication to commence today.
So, Catherine, if you don't mind popping a message in the chat for people to like when they're done, that would be really helpful. And then just letting us know when they're finished.
No problem.
Thank you, Queen.
Okay, we'll just give everyone a couple more minutes and then go through the question.
Yeah, I think that's usually pretty good.
So 16 people have had a go at the first question.
Okay, we can.
Yeah, it's like a quarter. That's usually how many people like the message. The rest kind of just do.
Fab. Okay, so can I go for the next slide, please?
Oh, yeah, that's me, isn't it?
Yes. Okay, so this patient is looking like they are in the midst of a manic episode, an acute manic episode on a background of bipolar type 1. So we're looking for a medication to treat the acute mania. There's a few options that we can go through. I've gone for olanzapine. It's an antipsychotic that has a relatively good side effect profile. The patient's quite young, So in terms of cardiometabolic things, it's not too big of a concern. And then if you have a look on BNF, the dosage that you would look for the indication of acute mania would be 15 milligrams, given orally once daily. If you click again, Charlotte, this is what the treatment summary heading would look like. And then if you click again, and one more time. Okay, so acute mania, we've got a few options. So antipsychotics. Actually, the mania and hypomania treatment summary has a really nice kind of guide on this. So antipsychotics, we've got olanzapine, haloperidol, risperidone, and quetiapine. I don't like to prescribe first generations if I can help it because of extrapyramidal side effects. So I just went with olanzapine. We could go for lithium, but if you just go back to the question, Charlotte, right at the bottom in the social history that no one can be bothered to read usually, it talks about how this patient struggles getting into clinic and has DNA'd appointments before, which is did not attend. So we don't want to be prescribing him something that if he requires lots of monitoring for, which you do for lithium, he's not going to be able to attend for that lithium because titrating it may not be safe. So if you could just click again, please, Charlotte. So yeah, lithium, when we're titrating, initially we're looking at about 2 or 3 times a week, checking bloods, and that's the lithium levels 12 hours after taking it. And so we need to ask, is the patient able to attend for that? Another option is sodium valproate. But again, I try and avoid prescribing it where possible, especially in childbearing age ranges. So in males, it can impact fertility, and actually the BNF has been updated with that information. It's also teratogenic. If it is something that can't be avoided and it's being given in a childbearing female, then we need to make sure that the patient's been properly counselled and considering a contraceptive to go along with that as well. Next slide, please, Charlotte. The other side of bipolar affective disorder, we've got the acute mania that we manage, and then we look at maintenance as well. Sorry. So a lot of the medications we use for acute mania can be used for maintenance as well. So that's lithium, sodium valproate, and antipsychotics as well. But there's a couple that you can use for maintenance alongside those. So lamotrigine is a really good medication, a really great mood stabilizer, and actually has a very good side effects profile. The only thing to be aware of is that it has a risk of Stevens-Johnson syndrome, especially when you're starting it. So the way I've seen it prescribed usually is you commence on 25 milligrams once a day, and you only increase by 25 milligrams every 2 weeks. And because of that slow titration, it can't be used for acute mania. The other one that I haven't mentioned on this slide would be carbamazepine. And the reason I haven't mentioned it is, again, it's got quite a big side effect profile. It's quite a dirty drug, can cause agranulocytosis. So you just avoid it if possible again. I put a bit of a note there for lithium. So lithium comes in a salt form that's either carbonate or citrate. Lithium carbonate is like the tablet form and citrate is liquid. And I most commonly see lithium carbonate being prescribed. And so I would just stick to that where possible. The only thing to be aware of on top of that is that the bioavailability of lithium can be very funny between brands. So it's really important that you specify the brand that you're prescribing and you stay consistent, because even lithium carbonate between brands, so in Winchester we use Priadel, can vary and can mess the patient up a lot. Can I get the next slide, please? Next question. And yeah, if you guys can let us know when you've finished. Let me put it in the chat.
Let us know when a similar number have done the question again, please, Catherine.
It looks like we've stabilized on 12, so
Lovely stuff. Yeah, just go ahead. Do you want the next slide?
yes, please.
Lovely.
So this is a 42-year-old female, and the presentation, I think, in psychiatric PSA questions is usually quite obvious. So low mood, poor sleep, and then importantly, early morning waking, and poor appetite, and noting that her clothes are fitting more loosely, so a bit of weight loss and poor sleep. Past psychiatric history, treatment-resistant depression. So she's trialed 2 SSRIs already, sertraline and fluoxetine, and they haven't been effective. And then in terms of past medical history, she's got hypothyroidism and hypertension. So for this patient, I've gone for some mirtazapine. And I intentionally kind of included this question because I think the BNF isn't that helpful if you're looking for through treatment summaries for what to prescribe. So the choice of mirtazapine is you don't want to go SSRI because you've tried 2 SSRIs already. So we're thinking second line. And then specifically mirtazapine can increase appetite and it can cause have sedative effects. So if the patient's taking it in the evening, it's kind of doubling up as a sleeping tablet and helping with their eating, and it's approaching the low mood through a different mechanism of action. So that's kind of the rationale going for mirtazapine. I've included vortioxetine on there. Charlotte, if you don't mind clicking again. And again. And again. So if you look at the treatment summary, I think it's for depression. Vortioxetine is mentioned as a treatment option that can be considered for patients with treatment-resistant depression who have trialed 2 antidepressant drugs. So I don't think you'd be wrong in prescribing vortioxetine. It's got quite a good side effect profile and it's supposed to have good efficacy. My consultant thinks it's actually just pharmaceutical companies kind of pushing it a bit and it not being actually that efficacious. But the reason I would say mirtazapine is preferred to vortioxetine is specifically addressing the patient's symptoms. So click again, please, Charlotte. And again. So antidepressants, we've got quite a few classes of antidepressants. Generally, first line, we go SSRIs. So that's things like sertraline, fluoxetine, citalopram, S-citalopram. They have a pretty good safety profile. Fluoxetine is particularly helpful in patients under the age of 25. It seems to show that it's got slightly better efficacy than the other options. The thing to be careful about with particularly sertraline is that there is an increased risk of suicidal ideation when you're initiating it. And so it's really important to counsel the patient on that and to closely monitor. So within a week, kind of arranging a follow-up appointment. Next up, we've got SNRIs, so serotonin noradrenaline reuptake inhibitors. That's things like venlafaxine and duloxetine. They're really good for patients who are saying they're struggling with energy and motivation. But on the flip side, if you think that they increase energy, For some patients, it can increase the energy before it's increasing their mood. So again, you have that risk of suicidal ideation and action to think about when prescribing it. So you need to follow up closely. And it can, because of that increase in energy, also translate to insomnia and anxiety. So you need to be aware of it. Having said that, duloxetine particularly is very efficacious, particularly at higher doses. And it's really good for neuropathic pain. So if you've got any patients who are comorbid and struggling with neuropathic pain, it's a really good option to go for. And then the other thing to say about SNRIs is just venlafaxine specifically. You have a risk of withdrawal if you discontinue it quickly. Not that withdrawal would be life-threatening, just that it would be very unpleasant for the patient and they wouldn't thank you for it. So it needs some counselling. MAOIs, monoamine oxidase inhibitors, I've never seen prescribed. I think they interact with tyramine-rich foods and other medications. And I would say that's a very specialist decision to choose to start those. So don't worry too much about those. And then we've got mirtazapine, which isn't really mentioned in treatment summaries, but is a very good option, particularly in patients who may be struggling with disordered eating, insomnia, and reduced appetite. And then we've got our TCAs to finish off, and that's things like amitriptyline, clomipramine, and amitriptyline can also be used for neuropathic pain, but we generally avoid these in our psychiatric patients because there is a high risk in overdose, and they're cardiotoxic, and they have just a big side effect profile as well. I've just seen a question: if the patient wasn't struggling with insomnia, would SNRIs be next line to treatment-resistant depression after SSRIs? Yeah, so there's not like a definitive you would go straight to SNRIs, but they are a good alternative to consider. Yeah, and there's not like a this is first, this is second. It's looking at the patient as an individual and seeing what their needs are, but SNRIs are a good place to go as well. Next slide, please. Next question.
Sorry, can I just add something about mirtazapine?
Yeah, go ahead.
So just something for you guys to be aware of, that mirtazapine works a little differently depending on the dose you prescribe. So the lower doses, say like 15 milligrams, are much more sedating. So that would be really helpful, for example, in the last case with insomnia. But as you increase the dose to sort of 30 and 45 milligrams, which is max, that's when it really has an impact on depression. So just a bit of a practical tip there for you guys when you start F1.
If you guys could just let us know again if you finished the question.
So we've got just under 10 people who've given it a go so far.
Okay, fab. Okay, cool. Next slide, please, Charlotte. So here we've got a 29-year-old male. He's got a diagnosis of schizophrenia, and he is presenting with what looks like acute psychosis, so the auditory hallucinations and paranoid delusions. If we have a look at past medical history, he's got obesity with a BMI of 37, which is going to be important to consider when we're thinking about what medication to prescribe him. And then just a bit about the social history again. So I've gone for some aripiprazole for this patient at a dose of 10 milligrams once a day and typically given in the morning. And Charlotte, if you could click again. So there's lots of options for antipsychotics, and there isn't just one right answer. I've gone for aripiprazole because I'm familiar with that medication and I know it doesn't cause weight gain, which is really important to consider, and actually can cause weight loss. So in a patient who's obese, obviously you don't want to give them a medication that's going to cause them weight gain. So I'm going to use this table to just talk about the overarching side effects you can get with antipsychotics. Extrapyramidal symptoms, generally you see that with first generation antipsychotics. So you can use first generation. I do see haloperidol prescribed commonly, but I like to avoid it because of those extrapyramidal side effects. We've got anticholinergic effect, so sedating, kind of dry mouth, all of those things, falls risk. And then we've got sedation, orthostatic hypotension, and then weight gain and diabetes. So if you go one more click, please, Charlotte. This is kind of my summary of antipsychotics that I learned for PSA. So first generations, lots of extrapyramidals and metabolic side effects. Aripiprazole, alongside other ones, so things like amisulpride is quite good as well for side effect profile. And it doesn't cause sedation, doesn't cause weight gain, doesn't cause hyperprolactinemia, and actually can lower prolactin levels despite what it says in BNF. But the thing about aripiprazole is you take it in the morning because especially when commencing it, it can cause agitation and anxiety in patients. And sometimes I've seen consultants prescribe diazepam alongside aripiprazole for those first couple of weeks, just so the patient has it PRN if they need it, as they're getting used to the medication. Risperidone famously causes hyperprolactinemia, so alongside all these other side effects like weight gain, hyperprolactinemia is the one you see in risperidone. Quetiapine is very, very sedating. Olanzapine is particularly bad for weight gain and type 2 diabetes. And then we've got clozapine, which is like the best antipsychotic. It's the only one really that has shown proper evidence of being more efficacious than the others. And it's just got an absolutely awful side effect profile. So constipation, risk of agranulocytosis, myocarditis, prolonged QTC, all the metabolic stuff. Actually not extrapyramidals, but like aside from extrapyramidals, basically it's the worst for everything else, which is why it's only ever prescribed in treatment-resistant schizophrenia, and the way that's defined in this case is patients who've trialed 2 other antipsychotics without sufficient effect. What about amisulpride? Yeah, amisulpride is another option that can be used. I think also doesn't cause much weight gain. Yeah, can we go to the next slide, please? And again, please. I think the treatment summary, not all the psychiatric treatment summaries are helpful, but I think the psychosis one is, and if you're stuck on which ones are worse for which side effects, it has a good summary on there as well. So this is the next question.
So 6 people have given the question a go so far.
You're muted, Moji.
Thank you.
You're welcome.
Okay, so we've got a 67-year-old inpatient who is currently agitated, shouting and threatening to kill staff on the ward. He's refusing oral medication and de-escalation techniques have not been effective. So in this patient, we're looking at acute agitation. Past medical history of Parkinson's disease, which is really significant. Current medication includes levodopa, carbidopa, 125 milligrams 3 times a day. And then there's some OBS there for us as well. So Charlotte, if you could click again. So I've gone some lorazepam in this patient. The fact that they've got Parkinson's disease would suggest that I wouldn't go for anything like an antipsychotic like haloperidol or olanzapine, and that's because if in Parkinson's disease we're concerned the patient doesn't have enough dopamine, we don't want to give something that's going to block dopamine because then their Parkinsonism's going to get worse, obviously, and so we avoid, it's contraindicated. So in this case, I've gone for some lorazepam. And then in terms of dosage, the BNF isn't very helpful when it comes to acute agitation. And it's just about a small dose of lorazepam. So I would go for 1 to 2 milligrams. I asked my colleagues and they were like, yeah, I'd give 0.25 milligrams. So it really is a very small dose, and then reassessing regularly because you don't want to oversedate your patient because then you're worried about respiratory depression, etc. Cool. If there's, yeah, let's move on. So that's all of our prescription questions. We're on to prescription review now.
Have people had
Just
a go,
under
Catherine?
10, yeah, just under 10 people have given it a go so far.
Thank you.
Lovely.
So you're in F1, reviewing the drug chart of a 72-year-old man admitted to ED. He's got increasing confusion, drowsiness, and a coarse tremor. He's got a history of bipolar affective disorder, hypertension, CKD stage 3B, and osteoarthritis. He's on various medications: lithium, ramipril, amlodipine, paracetamol, and senna. And on examination, He's a bit tachy, afebrile, and importantly has a coarse tremor. So for part A, I've just been annoying, to be honest, and placed a medication right at the bottom of the prescription review with the dosing error. So that is Senna, Charlotte, if you don't mind clicking, 150 milligrams. Senna is typically given around 15 milligrams. And I kind of put that in there to illustrate it's helpful with medications that are common and they'd like putting in prescription reviews for the PSA. It can be helpful to know a kind of ballpark of what the dosage of that medication is. So like vaguely knowing that 10 milligrams of ramipril looks about right, paracetamol 1 gram 4 times a day looks about right, and that Senna 150 milligrams definitely looks wrong, I think is helpful knowing. Things like atorvastatin, omeprazole, those are the ones I'd recommend, not necessarily memorizing, but just kind of being aware of them and having used them enough to know that, you know, a dose of 200 milligrams of omeprazole isn't right. And then for part B, Charlotte, if you don't mind clicking twice. So we've got the lithium at 800 milligrams and ramipril at 10 milligrams. So this patient is experiencing lithium toxicity that presents with confusion, drowsiness, coarse tremor, and generally feeling unwell, nausea, vomiting. And a thing to be aware of is if you put lithium and ramipril both into an interactions checker, it will say that ramipril can increase the effect of lithium and cause buildup of lithium. And that goes for lithium and any kind of nephrotoxic medication. It can also be nephrotoxic itself. So we try and avoid lithium with things like ramipril, any NSAIDs, anything like that. Yeah, if you don't mind clicking, Charlotte. So I've just included like common things that they include on prescription reviews to be aware of. Some of them are quite straightforward, like dosing errors. One thing that used to catch me out a lot is patients who had renal comorbidities and are being prescribed the wrong dose of certain medication like lithium. And the other one is drug interactions, which if you stick them in drug interactions checker can be really easy to check. So lithium with any nephrotoxic agents, like we said. And then things like antidepressants, multiple antidepressants, or too many psychotropic medications together, or a psychotropic medication alongside an illicit substance like MDMA can increase the risk of serotonin syndrome as well. And then just straightforward ones like side effects, contraindications, and allergies. Yeah, cool. Next slide, please.
Has it come up?
Sorry?
Has it come up?
Yes.
Yeah, thank you.
Oh, thank you, guys.
Just under 10 people have given it a go again.
Thank you very much. So we've got a 19-year-old female patient who essentially is presented with symptoms of and been diagnosed with generalized anxiety disorder. And we're essentially looking at first-line treatment of that. Charlotte, if you don't mind clicking. Going with some escitalopram at 10 milligrams once daily, which is an SSRI. There's another antidepressant on there, venlafaxine. The dosage wouldn't be appropriate for initiating. You'd be looking at a much lower dose. We've got zopiclone, which is a sleeping tablet, which isn't going to address her generalized anxiety disorder. Similarly with diazepam, it's just going to sedate her. The only one to be aware of is buspirone, which I hadn't actually come across in med school, but it's a medication that can be used to treat anxiety, but it's more commonly used for kind of short-term anxiety. So this patient's symptoms have been ongoing for 6 months, and also SSRI is just a good first line generally to use. If you don't mind clicking, Charlotte. Next question.
Now's probably a good time.
Thank you very much. So we've got a 46-year-old male patient with a diagnosis of schizophrenia, who's missed 2 doses of clozapine and has attended today to receive his medication. This patient has a diagnosis of schizophrenia, like we said, past medical history of type 2 diabetes. There's a list of medications. So what do we do for this patient? Charlotte, if you don't mind clicking. The answer would be D, to withhold clozapine and restart at a low dose, titrating upwards. Many of the risks that are associated with clozapine, including agranulocytosis, are at their highest when you're initiating clozapine. And when a patient's missed 48 hours worth of medication, it's essentially as if they're starting it again when they take it. So you can't just continue on the 250 milligram dose they've been on. You would need kind of specialist intervention and advice on how to commence that clozapine to minimize the risk of relapse occurring of psychosis. You wouldn't immediately restart clozapine and monitor closely because of that high risk of things like agranulocytosis and also myocarditis. You wouldn't just switch to risperidone. If the patient's on clozapine, it's likely that they've trialed previous antipsychotics and they haven't been efficacious enough. So again, you have that risk of psychosis. You wouldn't give an extra dose because that would defeat the whole purpose of titrating it, which we've talked about. And you wouldn't necessarily send the patient to ED because they're not currently at a risk of infection because they haven't taken that extra dose of clozapine after a break. Next slide, please. So a few medications to go through for some high yield prescribing knowledge. We've kind of talked a bit about clozapine, but just to reiterate, when you're commencing it, it's important to have slow titration to reduce the risk of these severe adverse events. Generally, patients will attend clozapine clinic where they can get their bloods done and they can be administered that clozapine. That helps also making sure that the patient's actually taking the medication, but also closely monitoring them. And then, as we said, if the dose has been missed for 48 hours, you need to withhold and retitrate. Any patients who are on antipsychotics will have an annual physical health check. And I'll kind of talk later on about what that entails, but it's generally like a big set of bloods, ECG, things like that, to make sure that they're okay. Escitalopram is an SSRI, often used in anxiety and depression first line. It's an isomer of citalopram, and it is what citalopram is converted to in the body. So theoretically, it's a more efficacious version of citalopram and should have fewer side effects as well. That being said, both of them can cause prolonged QTC interval. And so you need to be mindful of that and kind of do an ECG at a baseline and on the medication to make sure that's not happening. For any patients on antidepressant therapy, it's important to continue their treatment for at least 6 months after remission if they have depression, and it can be up to 12 months for patients with anxiety disorder, and that's because of risk of relapse of symptoms again. Sodium valproate, I won't linger on too long, but essentially we've already talked about it. It's teratogenic and can affect fertility for men. Diazepam, I do actually see quite commonly prescribed in community mental health, generally not for more than a couple of weeks because of that risk of dependence. But it can be really helpful for patients who are really suffering with severe anxiety and they just need something to bridge them to when their SSRI is going to start working, which can take 4 to 6 weeks. Oh, and then the note that I've included is that antipsychotics can come in depot form and they can last for up to 6 months. And obviously in patients who are on continued treatment orders or patients who can disappear on you, which does happen, giving them a depot injection that lasts 6 months that they can then go and run away and do whatever it is they do. You don't have to worry about administering their medication. So that's another consideration to bear in mind as well. Can I get next slide, please? So drug counselling question now.
Now's probably a good time.
Thank you. So we've got a 48-year-old patient with generalized anxiety disorder commencing venlafaxine at a dose of 37.5 milligrams. Past medical history of type 2 diabetes, and they're currently on metformin. So what's the most important piece of information to give the patient? These questions always annoy me because there's always at least 3 of the answers that you think can be kind of quite reasonable answers. But Charlotte, if you don't mind clicking. In this case, it would be B, the fact that it may increase the patient's blood pressure at higher doses. And these questions you'll see lots of them that are very similar, and they all have a different answer to each other for different reasons. So this patient is 48, they already have diabetes, so we need to consider their cardiometabolic risk factors really carefully, and they need to be aware of their long-term risk of things like heart attack and stroke going forward, which is why in this patient it's so important that they're aware that it can increase their blood pressure, also so we can monitor it and address it if need be. The fact that it can take 4 to 6 weeks to feel the therapeutic effect is really important, but in older patients, that increased risk of suicide waiting for the medication to work isn't always there. We don't really have anything on the patient's risk. So if this question said that this patient had a lot of suicidal ideation, that answer might be different. And really we're looking for, is there anything that is urgently life-threatening for this patient if we don't tell them, and is there anything life-threatening in the long term? And those are how I would prioritize the answer to these questions. C wouldn't be the most important because withdrawal symptoms aren't life-threatening, so whilst they would be very unpleasant, they aren't the most important. And then the side effects, again, isn't that big of a deal compared with mortality risk, and alcohol isn't necessarily true. They don't necessarily need to avoid alcohol. Next question. Thank you. How are we doing?
Lots of answers already.
Great,
Go
thank
for
you. So we've got a 21-year-old male patient commencing sertraline for a moderate episode of depression lasting 4 months. He's suffering with anhedonia, early morning waking, low mood, and suicidal ideation. So this is essentially a bit of a follow-up question from the last question. So Charlotte, if you don't mind clicking, is that this patient may experience increased suicidal ideation, and they need to be followed up closely. And because the patient is young, that risk is slightly higher as well. So it's really, really important that he's aware of that. It is also important that he doesn't discontinue his medication for 6 months following remission, but it's not necessarily immediately life-threatening. Next slide, please. So a few kind of high-yield bits for drug counselling. We've kind of talked about sertraline already, but the other one to know is that SSRIs can cause a lot of GI upset, and actually that's probably the most common side effect that people complain of, as well as reduced libido. They can also get symptoms of reflux as well, and obviously you can think about prescribing some omeprazole to go along with that. And then just making sure that the patient is aware that it can take up to 6 weeks before benefits are seen. Usually if benefits aren't seen by about 2 months, we would be thinking about switching SSRI. The other pitfall to be aware of is that this happens a lot with GPs, and we see it in community mental health, where it will say patient hasn't responded to so-and-so SSRIs, and they've given it at the very lowest dose. And a lot of these medications aren't really efficacious until you get to those higher doses. And so unless it's been titrated, it's hard to say whether it is going to work for the patient or not. Olanzapine, we talked about kind of earlier on, and there's a bit of repetition going on here because I think that's what PSA is all about, to be honest. So it's used to manage psychosis. It can also be used to manage mania. has lots of anticholinergic effects, metabolic side effects. It's very sedating. And with antipsychotics generally, you should not discontinue them quickly because of a risk of relapse of psychosis. And that goes for particularly with QTC interval prolongation. So we had a patient who was actually on clozapine. They had an ECG in hospital for an unrelated health condition. Their QTC, which normal range was said to be below around 450, had gone up to 480. So they discontinued this patient's clozapine. He had a huge relapse. He ended up having to be admitted under a Section 3. Really, really disruptive to his life. And actually, 480 isn't that high and can just be monitored and lowering the dose of that medication. So no rash decisions when it comes to antipsychotics. And you should always be kind of speaking with a specialist. And then Zopiclone I've just included is a sleeping tablet. Again, it's only ever given short term if possible because there's a risk of dependence. And sedation with Zopiclone, even if you take it in the evening, can go on throughout the next day as well. So patients need to be cautioned about that, and they need to be aware of that for driving, and they shouldn't really be driving if they're on sedating medication. And Zopiclone can also increase the effects of alcohol as well. So that's one thing to counsel on. Next slide, please. Adverse drug reactions.
I think people are a bit unsure on this one, maybe.
No worries, we can talk through it. So we've got a 25-year-old female patient who is attending ED with hyperhidrosis, which is excessive sweating, agitation, and rigid muscles. She reported that she's taken something, but we're not given any further information. Patient has a history of generalized anxiety disorder. So on examination, we've got hyperreflexia. Patient is pyrexial with a temperature of 39.5 degrees, tachycardic, and the blood pressure is slightly on the higher side as well. So which of the following medications is most likely to have caused her presentation? Charlotte, if you don't mind clicking. So citalopram. This is a bit of a tricky one. So it's what I'm getting at here is the interaction between citalopram and other recreational drugs like MDMA. So the patient's taken something, and in this case, we've got a serotonin syndrome, and it's interacted with an SSRI, which is a selective serotonin reuptake inhibitor, so increasing the amount of serotonin. And it can be quite tricky to diagnose, and it can be easy to miss. Key things you're looking for is hyperreflexia, pyrexial, agitation as well. Can I go for the next slide, please? Next question.
Probably a good time now.
Thank you. So we've got a 75-year-old male patient who's attended his GP with symptoms of severe anxiety. He's been agoraphobic, socially isolated. So the GP commences him on some sertraline at a dose of 50 milligrams, and also gives him a bit of a bridging dose of diazepam in the meantime. He's got anxiety, depression, hypertension, and type 2 diabetes. He's on sertraline, amlodipine, diazepam now, 2 milligrams PRN, up to 3 times a day, and sitagliptin. So we're looking at what the most likely side effects he's going to experience commencing diazepam. These also annoy me because there'll be multiple side effects that are listed under common in the answer, and it's really hard to distinguish which one it is. But Charlotte, if you don't mind clicking. The one I've gone for here is drowsiness. So benzos can cause respiratory depression, but their main mode of action is GABAergic kind of activity throughout the whole brain and whole cerebrum. So it's not that it necessarily works right on the brainstem the way an opiate might and cause respiratory depression. So it's only in higher doses we would see that. So that 2 milligrams 3 times a day is pretty unlikely to cause that. Similarly, diazepam with a 1-week supply, the reason we give short supply is to minimize the risk of withdrawal syndrome. So again, with a low dose, that's PRN and only there for a week, we're unlikely to see that withdrawal syndrome. Agitation isn't a very common side effect, and neither are blood disorders, and so the one you'd go for is drowsiness because of that. Next slide, please. So a few medications, and then we can kind of go through some of their side effects. So lithium commonly causes a fine tremor, can cause nausea, can cause diabetes insipidus, and weight gain as well. And I see a lot of patients on bipolar affective disorder who are looking to switch to an antipsychotic because of the physical health impacts that lithium is having for them. Renal impairment being a really important one, hypothyroidism, but also affecting the parathyroid as well. And then lithium toxicity is very serious, leading to encephalopathy. So we see that coarse tremor, nausea, agitation, feeling unwell. Daridorexant is quite a new medication that I hadn't come across until community mental health. It is a sleeping tablet, and it doesn't cause any dependence. So it's a really handy sleeping tablet for patients who are struggling with their sleep. Unfortunately, it can cause nightmares and sleep paralysis in a certain number of people, and obviously that's not helpful for patients struggling with their mental health. But otherwise, it has a generally safe side effect profile. Fluoxetine, like we said with SSRIs, causes GI disturbances. The one that's a bit funny with fluoxetine is these temperature abnormalities, so like chills, and there's quite a few kind of temperature intolerances that are listed in the BNF for it as well. It can cause QT prolongation, hyponatremia, and then the other one we're going to talk about is clozapine. So we talked about agranulocytosis and myocarditis already, and we know about the other side effects of antipsychotics like cardiometabolic risk factors. Clozapine also causes constipation, and if that's not closely managed, there is a risk of intestinal obstruction there, so you need to be really careful. And then there's also hypersalivation, and you can give, I believe it's hyoscine bromide, I'd have to double check that to help with that hypersalivation. Next slide, please. Next question.
Now is probably a good time.
Thank you. So we've got a 45-year-old female patient now with a history of bipolar affective disorder. She's on lithium and she's having her lithium levels checked. She's on lithium carbonate. When should her blood tests be taken? And that is 12 hours after her latest dose. Charlotte, if you don't mind clicking. And that's because when we're titrating lithium, yes, we want a therapeutic effect, but we also want to avoid the risk of toxicity. And so we want to know what the lithium levels are doing 12 hours after the dose is taken, so we can assess how much is in her system. Next question, please.
Now is good.
Thank you. So we've got a 44-year-old male patient commencing risperidone 2 milligrams for ongoing chronic psychosis, and they've got a diagnosis of schizoaffective disorder. He's been advised he needs some tests prior to commencement, so baseline tests essentially. Charlotte, if you don't mind clicking. So it's A. So with risperidone, we've already talked about how it can cause hyperprolactinemia. So I would definitely want a baseline prolactin for this patient before starting on risperidone. That rules out CDE. And then looking between A and B, the main distinguishing thing is that we would like an ECG for patients on antipsychotics because we want to know a baseline for their QTC to look for QTC prolongation. We don't particularly need a chest X-ray, for antipsychotics. It's not particularly clinically indicated, so that's how you would distinguish those. If you could click again, please. Yes, so annual physical health checks. You do kind of your basics, FBC, Usinese, LFTs. You want to check patients' thyroid, particularly if they're on lithium, bone profile for calcium, lipids, prolactin, B12 and folate, ferritin, and then ECG as well. And that's done every year with a full kind of assessment of height, weight, all of that stuff. Yeah, next slide, please. So this is like a 2-slide question. So I'll let you guys read the first bit and then we'll go to slide 2 for the question itself. So Charlotte, if you don't mind clicking. So it's looking at what to do with this patient's lithium. Do you mind going back, Charlotte, please? And then forward again, please. So we can kind of talk through this one now. So looking at serial lithium levels to start with, we can see that they're kind of slowly creeping up. The range that we were given in the question was 0.6 to 0.8, and it can vary for patients for what's therapeutic for them and kind of minimal side effects. So we're going from 0.7 to 0.9 to 1.2, which is out of the reference range as well. So we're not necessarily happy with the dose of lithium right now. The EGFR is also very, very gently kind of creeping down. So we're going from 88 to 80 to 72, and ideally we want it to be over 90, obviously. So we wouldn't necessarily just continue the current dose because we can see that there's something wrong with the dosing. So the top two options are kind of out. Charlotte, if you don't mind clicking. So we would go for C. And the reason we're going for C and we're not necessarily stopping lithium and going all gung-ho with IV fluids is because there's not really any signs of toxicity. She's a little bit nauseous, but otherwise well in herself. So we have time to reduce the dose of that lithium a bit. And then obviously because we're changing the dose of lithium, we need to monitor it closely. So repeat the level in 5 days again. If the patient had any kind of coarse tremor, if they were being sick or just generally unwell, then we would look at stopping lithium and starting IV fluids, and we'd want to make sure we're checking kidney function again as well. And we're not increasing lithium dose because the lithium dose is already too high. And next slide, please. And then one more click. And this is, again, a 2-slide question. So if you have a read, and then we can flip to the other side. And then if we could flick again, please. Do you mind going back a slide, please, Charlotte? And then forward again.
I think now is good. This might be slightly harder than the others.
No, that's all right, thank you. So we've got a 22-year-old patient who has taken a paracetamol overdose. We know that that happened 4 hours ago, and we know that current serum levels are 160 milligrams per litre. If we have a look at this graph, 160 is like off the scale, and we are past the 4-hour mark, so we're definitely over the treatment line. So we're looking to treat with NAC, definitely. And then just for the dosage of NAC really to decide, there's a couple of regimes that are mentioned on the BNF. You're not expected to choose which regimen to use, You're just expected to be able to identify whether a correct dose is being given for one or the other. So the only one on there that is included in a BNF regime is D. Charlotte, if you don't mind clicking. And that's at 100 milligrams per kilogram over 2 hours. That's the 12-hour SNAP regime. There is also a 21-hour one, but the 50 milligram just isn't the dose you would use. And I think that's the last of our questions. So thanks very much, everyone. I'm happy right now if anyone has any kind of BNF questions related to what we've just done. If you wanted any kind of demonstration going through the BNF and kind of talking through how to get to certain answers, I'd be happy to kind of share my screen and do that now. And obviously, if you guys have any questions, happy to answer those as well.
Thank you everyone for coming. The feedback form's in the chat if you don't mind just making sure you fill that out. It's really valuable for our teachers. Oh, you're welcome, Paul. Thanks for coming again. Thank you, everyone. Oh, Jamshid's just got a question. Is it better to use Medicine Complete over BNF interactions? Jamie, I think you don't actually get the BNF interaction one in the PSA. I think you have the computer one, so we only get Medicine's Complete interaction checker. I'm pretty sure is what they said in the PSA workshop the other day. So I don't think it's even like a choice of the two.
Yeah, you don't. The interaction checker is only on the app for the BNF, so and will be on computer screens, as far as I'm. Or you guys will be on computer screens. So that's the only thing I use Medicine Complete for. Some people use Medicine's Complete as their BNF, but that was too much for me.
Yeah, there's a lot going on. Med student unverified back again. There's always someone who goes by med student unverified. They've asked about slides. I'm gonna get my secretary or one of our resource coordinators to get on putting access to the slide section for people that have done the feedback form. It might take a little while, but we're not really getting good response from people who've got the recordings filling in feedback. So if you know anyone who's watched recordings, tell them to fill in the feedback and then we'll release session 2. But until such time, we will be gatekeeping. And then we'll do slides for you guys who came. So thank you so much for attending.
Thanks, guys.
Thank you. I'm going to stop recording. I forget I can stop recording.
Oh, yeah, please.
Thank you. That was so good.